And today I'm going to talk about crossing and reentry tools in CTO interventions in PAD. All right, let's see if that works. Here are my disclosures related to this talk, but in full disclosure, I'll tell you that I'm equally conflicted by anyone that brings food to the cath lab. So here are the objectives for CTO crossing techniques. High technical success rate to cross the CTO. High safety rate, obviously we want low complication rates and low adverse events. Procedure time is a big component of what we do in CTO interventions, and we want that to be small. And minimize restenotic response following crossing with whatever intervention that we do, and preserve options for adjunctive therapy. So how can we achieve that? Well, the landscape of CTOs we know is pretty large. About 40% of patients treated for PAD have chronic total occlusions. And there are a variety of complications that have been listed for CTO interventions, such as perforation, dissection, embolization, increased radiation and contrast exposure, and it still remains the most common reason for open surgical bypass. So some of the factors that influence success in crossing these lesions are the length of these lesions, osteal lesions when they're flush occlusions, a lot of collaterals at the cap, either at the proximal cap or the distal cap, heavy calcification, and how long the occlusion's been around. And so here's an image, an aortogram with runoff down both extremities that show long CTOs in the SFA on both sides with reconstitution in the distal segment with good runoff to the foot with 3 vessels in the tibials. So how do you approach a patient like this? And what are your options? There's a variety of access options first, obviously going antegrade, going retrograde from the foot, and we've gotten extremely good at that. And the third option is obviously a direct puncture into the occlusion or a transcollateral revascularization through extensive collaterals if they're large enough. But again, some of the challenges in crossing these occlusions with wires is that the wires can buckle because of the fibrotic nature of the cap. They can enter the lesion, but then buckle, not allowing you to traverse through the cap, go subintimal around the proximal cap, or you get a wire across and you just can't get any other device to follow. And so some of the thoughts out there about intraluminal versus subintimal crossing has been debated for a long time, and there are pros and cons about both. Whether you're actively going subintimal and going around the occlusion and reconstituting or re-entering at the distal reconstitutive vessel and then treating the subintimal space versus actually traversing the true lumen. Well, let's look at some of the data. The XLPAD is the largest published CTO cohort that we have of 1,345 CTO lesions. And they looked at, this is just a registry, and they had 1,097 primary wire catheter crossings and 248 CTOs that were crossed primarily with the CTO device. And if you look at the breakdown of that as far as technical success rate, that you see that the success rate is higher with a primary CTO device crossing strategy. If you look at the results as far as frequency and repeat revascularization and amputation and death, again, there's a benefit based on this registry of using a primary CTO crossing device in crossing these occlusions. So what kind of devices do we have to be able to cross? And there's a variety of them. And what's considered luminal crossing within all these different companies, we have a variety of devices. And if you go subintimal, we have a variety of reentry devices as well. And we'll go through them quickly. But some of these devices have varying forms of going or traversing an occlusion depending on how fibrotic they are and what the primary mode of crossing them will be. And then the reentry devices, again, you have an assortment of reentry devices with the balloon-assisted reentry from the subintimal space up to imaging-guided reentry with the Pioneer catheter using IVUS. So let's look at what we know about the data in CTOs in the SFA. If you look at the data that we have in this particular study published in JACC Interventions, you see that the patency drops off significantly after 12 months depending on the length of the lesion. So if you have long stenting segments greater than 100 millimeters, you have a significant drop-off in patency, in primary patency after those first 12 months. And so here comes the push for shorter stenting and maybe spot stenting and decreasing the stent length. And how can you do that? Well, if you look at this particular study published in Journal of Invasive Cardiology, looking at crossing the occlusion via true lumen path actually impacts the TLR rate, or the target lesion revascularization rate. And so if you look at the primary endpoint here, these were IVUS-guided measurements in the Crosser study by Bard. If you were greater than 90% true lumen crossing based on IVUS, then you had a significantly lower percentage of TLR at 6 months. And so the question again becomes, how can you tell whether you're true lumen? And if you're not using imaging, it becomes extremely difficult. And so some of the studies have shown that if you use imaging and if you use IVUS guidance to look at what you've crossed, with, whether it's be by wire or a crossing device, you see that you create a lot of subintimal planes with wires. You can have hematomas, you can compromise collaterals, and you can even have extravascular hematomas from mini perforations. And so one of the other CTO crossing devices that we have is the OCELOT, which is OCT-GUIDED CTO crossing, allows you to picture where the catheter traverses through that occlusion. And so the image on the right shows you layered structures, and you keep the catheter away from the layered structures and direct it towards the plaque to be able to cross the occlusion intraluminal and guided by OCT imaging. And the data, again, from Connect 2 showed that the crossing success rate was pretty high. Freedom from major adverse events was extremely high. And luminal crossing was extremely high, again, confirmed by imaging. So here's that patient that I showed with the long CTO in the SFA. Showed a good tibial reconstitution with 3-vessel runoff into the foot. So this is a good retrograde case where you're able to access the PT in this particular case, showing intravascular intraluminal position, and a retrograde crossing device with the OCELOT pixel using OCT guidance to be able to cross the occlusion. And this is post-crossing and balloon angioplasty without any stenting at this point. You see small dissections in the proximal segment, small dissection in the mid segment, which would allow for, again, spot stenting rather than the stenting of the entire SFA. And with that, I'll conclude, and thank you again for this opportunity.